Welcome to a podcast on CLL and fatigue. My name is Renata Walewska and I'm consultant hematologist in Dorset. And today, to discuss fatigue in CLL, I'm joined by Charles Monroe.
Hello.
And David Bartlett.
Hello.
So, Charles, let's start setting the scene. Tell us your story before CLL and what happened when you were diagnosed with CLL.
Okay, so before CLL, or as a young man, I used to do a lot of exercise, but it was never structured. I would go out cycling. I would just go cycling when I wanted to. With my wife, we had various holidays. We took our tandem to Italy, cycled from Pisa to Naples, over to the Adriatic, down to, of course, Napoli, and then up, and then flying back, and various other holidays on mountain bikes in Sardinia and other places. So when CLL came along, it did coincide with a fairly pressured situation at work. As with a startup company, we had to get our technology working. And I got the diagnosis. I was starting to feel more fatigue. It crept up on me, the fatigue, but it was more and more difficult to do exercise. And the other issue, when I had that diagnosis, when I tried to do exercise, I would overcook it. I'd make myself ill. And it was a recurring cycle. This increasing the exercise, building a bit up, then becoming ill, back to base zero. Yeah, so that was my experience. And it was very demotivating because I saw my capability of doing things going down, and also I was making myself ill too often. So, yeah, that was my experience as a CLL patient, if you like. And this was before I started any treatment.
Yeah. And did you find that the CLL-related fatigue was different when you actually started the treatment? Or was it just one dark tunnel all the way in?
I think when I started treatment, I was very, very weak. Shortly after starting treatment, COVID came along. I also had kidney surgery, and I can remember coming out of that those months. I was so weak. I can remember going to see a physiotherapist, and for example, she asked me to touch my toes, and if I could give a demonstration, I couldn't get down very far. I could only get down to my knees. I'd have my hand on my knees, and she would say, "Straighten up." And I was walking my body back up to the upright position with my hands on my legs. So that was a measure of how much CLL had affected me, combined with all the other work-life situations. My work-life balance wasn't particularly good at the time.
Just quickly for podcast listeners, Charles just barely bent down to 90 degrees to reach his knees. That was all. I think the other thing, the fatigue was different. As a younger man, if you go out and do exercise, you could feel tired, but there was a satisfaction in it. This was more wearing. It sort of seemed to just bear down on you, I guess. But the whole increase in this, it crept up on you. You didn't notice it. It was a bit like growing up as a young child. You'd never see yourself get taller, but at the end of when you reached your teens and you thought, my goodness, I'm now a tall adult. And obviously, when we offer you, as a CLL clinician, we offer you treatment, one of the first side effects is fatigue. How did you take it? Obviously, you've got CLL, we need to treat you, and the first side effect is fatigue.
Yes, I can't. I've seen the results of your work, David, and I can see that the fatigue element gets greater with treatment, but I don't think I could distinguish that myself. But I just know whether going through the point to which I needed treatment, and then the treatment itself, the kidney surgery, COVID, it was a bit of a blur, to be honest.
So obviously you are also CLL Support Association member, and I know CLL Support did a survey just to see how common fatigue is amongst CLL patients.
I've been looking at those results put together by Hilary, Lindsay and Debbie, and it's very interesting because they got replies from 1,100 people, and more than half talked about fatigue, which almost is more than all the other replies put together. It's probably a third of the total ailments or whatever you'd call it for CLL sufferers. It's fatigue ahead of bruising, ahead of illness. All these things are in significance, but fatigue is the biggest issue. The other thing about it is people talk about bruising or illnesses or whatever as something that happens once every month or once every 2 weeks, whereas fatigue is something that people feel, half the respondents feel, that's the point, half the respondents talk about fatigue and they talk about it every day. So it is an ongoing thing that is very common to CLL sufferers.
And obviously in CLL patients with early stages who are on active monitoring, and yet we can't offer you treatment for it. So what was the feedback from CLL survey about what CLL patients trying to do about it? I mean, is there anything?
I don't have an answer to that question. Do you? I mean, I can remember the response when people would say, well, doing exercise is good for you. But for myself, I mean, I'm probably a bit of a headbanger when it comes to exercise. I've never been a top flight sportsman, but I don't know when to stop. Whenever I did do exercise, I made myself ill.
Yeah.
But your question was
addressing fatigue.
Yeah.
CLL.
I don't think I had any real advice from the clinicians that I was.
I mean, do our CLL's patients actually go to clinicians and ask for help with the fatigue? And
you're right. That survey by Hilary and Debbie, they talk about the fact that there isn't good advice. It's I don't want to be rude to clinicians, but it almost seems as if it's a bit of a brush off. Just carry on as you are and see what you can do. I hope I'm doing them justice, and please excuse me if that appears rude.
Well, I think here, just note to fellow clinician listening to this podcast, I think, yes, with early stage ACLL, yes, we're just actively monitoring, but I think it is important to investigate for other causes of fatigue, checking for anemia, low vitamin D, etc. Just basic MOT, which I think as a CR clinicians we should do as a minimum.
Yes, and I'm looking forward to talking about it, but talking about how I've overcome the fatigue problems. Well, that's going to come later on as we carry on talking.
So moving on, David, because I know you and your PhD student Ellie did a survey trying to delve into more what Charles has just described.
That's right, yeah. And it's fascinating hearing what you're talking about, Charles, because it just runs through everybody that we speak to and everybody that we get into our studies. And you know, I suppose at the end of the day, you really clarified what fatigue is. It's a very subjective matter, and it's very much about how you feel at any given time. But obviously the crux of fatigue is that you are simply exhausted and tired beyond anything that should cause that to happen, and then the recovery from it just doesn't seem to be apparent. It's not like when you were younger exercising, is it? And so that fatigue definition is just naturally inbuilt to what everybody says. And I always wonder whether, you know, as a patient, when they come to the clinicians, you know it's a subjective feeling, and so it's really hard to kind of confirm what is causing the fatigue and how do you put a number to it. You know, 1 to 10 is a great fatigue scale, but really how do you put that number to it is really difficult because it changes. And so we did a survey very similar to the CLL support survey with a few less people in it, and we were really interested in physical activity levels because we knew that physical activity is associated with benefits throughout cancer diagnosis, cancer treatment, and so on. And we were keen to see how much physical activity people were doing and what kind of things were related to the amount of physical activity you're doing. And sure enough, fatigue comes in as our number one a symptom of CLL, and we see differences between the people who are treatment naive versus the people who are treating. Sure enough, the people who are being treated have higher frequency of fatigue and feelings of fatigue. And then when we bring it all together to try and figure out what these relationships are, we start to see this association with physical parameters, and that kind of comes back to what the mechanism and the definition of fatigue is. And we know that fatigue is driven through two primary ways, one being the peripheral and one being the central mechanisms. And the peripheral is your muscle, right? And we know that muscle declines as you get older, and so older people start to feel more fatigue. And we know that cancer treatments can affect muscle, and so peripheral fatigue starts to kick in. It's almost like developing sarcopenia and cachexia. But there's this central part to it as well. And a lot of the research suggests that the central part of it is really the driving force. And this is the neurological side, where perhaps the brain isn't able to communicate to the muscles to be able to do it. And so this feeling of weight, of heavy weights around you all the time, and feeling of total exhaustion and total tiredness is driven by a brain function that isn't been able to communicate to the muscles. And we're starting to now really start to understand what the biology behind that is.
So within that survey, what are other predictors of?
Well, yeah. So in our survey, the main predictors of physical activity were physical function as an independent predictor, which we kind of realized that should be, and treatment. And so the people who were being treated were less likely to be physically active. But then if we break it down into the individual components of the predictors of physical activity, fatigue is one of the number ones predictors that comes out. And so the more fatigued you are, the less likely you are to be undertaking physical activity. And then it becomes a vicious circle, right?
That was very much my experience, that as your performance deteriorates, it's far more difficult to get out and try and do more. And yeah, you try really hard, but the motivation, keeping up the motivation is very, very difficult.
Yep.
That was my experience.
So let's unravel the cancer-related fatigue. So if you could just take us right to the basics. What's the physiological background of cancer-related fatigue, and what we've learned from solid cancers? Because obviously there's so much more work on solid cancers.
Yeah. So when you look at our survey and you see this treatment relationship where more people with fatigue have been treated for their CLL, and you take that into a solid cancer, we know that those solid cancers usually get a much more aggressive kind of therapy. They'll have chemotherapy, or they'll have radiation therapy and surgery quite often. And it's those kind of treatments that are really driving a lot of the fatigue. And so then the physiology behind that becomes quite peripheral to some extent, because you're affecting the muscles in the area. But at the same time, the cancer itself and the cancer treatments drive this inflammatory response. And this inflammatory response and this immune dysregulation that's present in all cancers really not only affects metabolic processes within the body, affects the neurological processes, but also affects the systemic muscle. And so the overwhelming evidence now would suggest that the majority of mechanisms that are driving cancer-related fatigue are around an inflammatory imbalance. So pro-inflammatory cytokines circulating around that seem to be driving the majority of the dysfunction that we see.
And obviously there are quite a few assessments, because we talked, you mentioned how to describe, and obviously there are some questionnaires.
Sure.
Could you tell us about those different questionnaires?
Yeah, I wish we had a really good questionnaire that kind of defined fatigue perfectly. But because fatigue's so complex, we don't really know, there's so many different etiologies of it in different cancer patients. So one assessment technique might not necessarily work for all of the patients. And because it's subjective, then the majority of assessments are driven by questionnaires. And so there are a number of validated cancer fatigue questionnaires, like the FACIT-F and the EORTC. They do really well at determining how much fatigue you have and kind of tickle you at where the fatigue is, which is great, because then it gives you an idea of where you can target. But it doesn't get to the mechanism of it. And as a scientist, I find that really difficult, because then I can't specifically target the mechanism. But yeah, the questionnaires are getting better and are much more broad. Physically, though, it's a lot harder. We do a lot of really in-depth physiological assessments in our lab, and the things that you would think would be related to fatigue quite often aren't. And so it's individualized to each person and how much fatigue they're feeling at that given time. So at the moment, we kind of have to stick with the subjective and do some physical assessments, but overall, it's a hodgepodge of different questionnaires and different assessments.
And I've heard you saying before that fatigue, because obviously when I think of fatigue, I think it's a plateau, one constant thing. But I've heard you saying that it's in waves, which I think to cope and to address it is probably very
Yeah.
important. Could you elaborate on that?
Yeah, so we see that quite a lot, especially in the chemotherapy world. That's an easy thing to be able to distinguish, because you get this chemotherapy-driven fatigue, and so a patient will go through their 5-hour cycle of chemo in the hospital, and then for a couple of days afterwards, they're feeling really exhausted and really tired because of the effects of the chemo. And so then when we get them into our lab to do some exercise, depending on when they've had that chemo, it could alter the way that we actually treat them. And so their fatigue is very wave-like, and we have to be able to account for that every time we see them, right? But in CLL, it's chronic at this stage, but at the same time, I'm still pretty sure it'll go in a wave, and it's trying to identify where the wave is peaking and troughing.
Interesting. I don't know whether this resonates with that idea, but we live on 3 stories, and going up to my office on the top story, there are some times where I think I can take the steps 2 at a time. There are some times when I think my legs are heavy, and it'll go days at a time, and I can't put my finger on it.
That's it. Yep. So the waves are there. It's just trying to identify them, right? And for us, we try to have a chat. If fatigue is really bad, and it's really kind of limiting your day-to-day life, then we're going to have a chat with you about when is it that you feel you're strongest, or start to record when you feel you're strongest or you're less fatigued, and then we can act at that point. But yeah, these waves are fascinating, and if you can identify them, then great. There's a lot of good technology out there now, like these monitors that people are wearing that can detect when you're stressed and you don't have much resilience. That's probably really well correlated with your fatigue at that point.
Yeah. Did you find maybe to chat? Are you watching your resting heart rate?
Oh, I
Or
well, not at the moment. I won't look at the moment, but yes, I'm now. This is embedded in my daily life.
So, fatigue in CLL or fatigue in hematological malignancies. In hematology, we see patients who are much less resilient, much more fatigue than solid cancer. Why do you think that is?
Yeah, that's a great question, Renata, isn't it? The evidence out there, the questionnaire data that we have that is all kind of getting compiled, suggests that people with blood cancers have the frequency of fatigue is much higher than in the solid cancers, and is much more severe than in the solid cancers as well. That's not to say that there's solid cancers out there that have the worst fatigue, but as a general concept, blood cancers seem to have more fatigue. And when we start to wonder why that is, we don't really have the evidence to really know for sure. But when you think of a blood cancer, then a blood cancer isn't localized to one area like a breast cancer or kidney, whatever the solid tumor might be. And because it's systemic and it's constantly circulating around, then it has a propensity to be able to affect all of the tissues much quicker. And so we suspect that because it is circulating, it's more like a metastatic cancer, then the chances are that's why it's a higher prevalence than what it is in the solid tumors.
And could you elaborate on that theory with fatty acids and CLL? Because I think this is
sure
quite a story.
Yeah. So CLL is a fatty acid driven cancer, and a lot of blood cancers are, to be fair. Whereas most solid tumors are kind of a glucose and a sugary type of cancer. But because the CLL is a fat-driven cancer, it sucks up a lot of free fatty acids that are in the blood, because it's circulating around, right? And then it uses those fatty acids to be able to promote its own survival. And that sounds great. You're like, oh, well, that sounds like a great cancer. I'm going to be thin. Brilliant. But what it does is it steals away those fuels that are absolutely essential for cardiac function and for skeletal muscle function. And because the heart and the muscles can't get the fuel that they need, you find this quickening of dysfunction. And the quickening of dysfunction becomes really apparent when you start to see a lot more people with CLL who are frail at a younger age. And so that is not a good sign, right? And we know that frailty is a driver of fatigue, and fatigue is a driver of frailty. They're they walk hand in hand with each other. And what we're trying to figure out with our studies is, can we redirect the energy away from the CLL cells and back into the tissues that need them? And of course, That's all fine and well if you're treatment naive. You've got a lot of the CLL cells kicking around, which are sucking up the fatty acids and changing the metabolic profile. But you have people who have went through treatment who don't really have very many CLL cells kicking around anymore. But in that sense, now what's happened is the damage has been done. And can we repair the damage? And when you look at things like cardiotoxicity, for instance, patients who go through, say, breast cancer chemotherapy, their heart never seems to recover from the damage that's done. And we think that potentially the CLL cell stealing the fuel is a damage that takes a lot longer than it should do to be able to be fixed. But then you go into a treatment, and the treatments are great at reducing the CLL cells and kind of bringing that metabolism back. But then they also have off-target effects on the skeletal muscle in the heart as well. So it's kind of like it's a progressive thing where the CLL cells start by stealing your fuel, and then as you go along, it just kind of gets worse and worse and worse.
So can I put you on the spot?
Yeah.
So what's your theory? How to steal fatty acids from CLL and redirect them to the heart and muscle?
So you've put me on the spot with this one because there's a new paper that just came out. Have you seen the new paper about the statins?
Tell us.
Yeah, okay. So the new paper came out showing that statin therapy in CLL improves long-term outcomes, and that's brilliant. But I don't think that everybody should be getting statins. Statins are good for some things and not good for other things. And most people with CLL suffer comorbidities and they have polypharmacy. So the more things you add to it, then the less healthy they're going to get. So the alternative, right, is exercise. We know that you can diet your way to reduce your fatty acids. That's great, but it takes quite a long time. But the exercise stimulates the muscle to uptake the fats. It stimulates the heart to uptake the fats, and it stimulates your good immune cells to reorganize.
So this is when you would shift the balance.
Exactly. You're shifting the balance through exercise, taking the fats from one area and putting them into the area that they need to be. And that's what the body does, right? When it's energy depleted, the tissue that needs it the most is the ones that will get that energy. And so exercise, in our opinion, is the way forward.
Yeah, we'll elaborate that in a
sure.
second. But before we do that, something which obviously I know you're planning a study on the diet, because obviously, you hear the low carb camp, but then what you're telling me sounds like low fat camp, low carb fat together. What do you advise to the patient?
Yeah, well, I wish I could give advice, but we haven't started that study yet. Looking at our metabolic tracing studies that we're doing, it for sure looks like that we can lower the amount of lipids in the blood. But with any cancer, what we don't want to do is promote a sarcopenic or a frailty kind of factor going on there. And so if we're taking away the lipids and some of the high carbs, then we have to be replacing that, right? And so the diets that we're choosing are like a Mediterranean-based diet and a DASH diet, where we are replacing the energy that we're stealing back from the fats with fiber and protein, which we know should help reconstitute the muscle and hopefully prevent this decline. But we don't know that for sure yet.
Right.
Not till we've done the study.
Yes, we are.
Our preliminary data suggests that. But
Sounds logical. Yes.
Yeah.
So you've heard that here first time, and hopefully we can prove it.
But the exercise seems to be working.
So let's go on exercise. So back to Charles. So obviously you were not a sedentary type of person, as we've heard from before.
Right.
So tell us more, how does exercise makes you feel? Up to the point before you met David and Ellie. Your own DIY exercise.
Okay, so I would try and recover when I'd been diagnosed with CLL, both before starting treatment and after treatment. I would try and I think I've got to rebuild my strength. I've got to rebuild my exercise. Even coming back from a holiday and having a nice relaxing time in the sun in Italy and thinking I'm going to start building things up again, I would start cycling. I was also doing some gardening, but with no sense of proportion, not listening to my body. I would overcook it and I'd make myself ill and I'd be in bed for a few days. And it was almost as if a few days being in bed, I'd gone right back to where I was before I started the exercise. And it was a recurring cycle. and it was very demotivating.
So in a way, that made you to stop exercise altogether, would you?
Yes, each time the gap before I was thinking I'd have another go got longer and longer. So the progression was less exercise, more sedentary lifestyle. Yeah.
Classic overtraining.
Yeah.
Yeah. Well, yes. Not listening to my body, but overtraining is one thing. It would make me ill. I mean, I can remember being in bed after these.
Yeah, and I've got to say, I hear those stories very often. And when I want to promote exercise, when somebody tells me, oh, I've just been out and had to stay in bed for a few days, yeah, this is very difficult to come back with alternative advice.
Yeah.
But hopefully we're going to give it at the end today. So, David, exercise and frailty, because I truly believe that frailty is a function of exercise, because and we know how detrimental frailty can be. So exercise is not some kind of luxury.
Nope.
It's a necessity.
Exactly.
So tell us more about frailty and the impact of frailty on chemotherapy, treatment, and coping with disease.
Yep. I mean, frailty is such a prevalent and horrible condition to be in, and it has such a weird etiology, doesn't it? It seems to be the more comorbidities you have, the more likely you are to be frail. But the effect that it has on people's quality of life and their daily function can lead to premature death. And so there's a lot of research out there now trying to figure out how to combat frailty. And for sure, exercise seems to be probably the most consistent at being able to get you over or out of that frailty kind of loop. And we know that it does that through muscular function. It builds strength and it builds physical reserve, but it also builds confidence and it promotes motivation to be able to get out there. When you get to the stage where you can't get out of your chair, then the motivation, like you say, Charles, just starts to disappear at that point. But if we can start slowly and we start to work you so that you're doing the things that are important for you, then we get you out, the motivation and the confidence starts to be regained, and you can do a little bit more. And then we add to that, and you can do a little bit more, and we can add to that to the point where the frailty just becomes an old part of what you were, and the exercise gets you out of it.
And I think it's important to add, I saw you once showing nice graphs of patients who are fit, who are able to do exercise, who when they've got a dip, so they are able to come back to a baseline.
Yeah, exactly.
So can you elaborate on those patients who are less fit, I don't do as much exercise, and the people who don't do exercise at all, who are in properly into frailty?
Yeah, so this is a resilience factor, isn't it? Where the less fit you are and the more frail you are, when there's an insult that happens, and in this case it may well be a diagnosis of CLL or whatever condition, your ability to bounce back from that is severely depleted, and you find that this gradual reduction in ability to be able to do anything, the steepness of the curve becomes out of control,
and the level of recovery.
And the level
slow.
Well, the level of the ability to recover takes much longer, doesn't it?
Yeah.
And so at that point,
sorry, can I add?
Yeah.
But it's also that graph. I saw that chart when you gave a talk, and you gave me the abdats. You go down lower, but when you came up, you didn't come up so high, and the more frail you were, or the further on you were,
it's a constant decline.
The bigger the gap
to
the recovery level. You didn't get back to where you were. When you're young and fit, you get back to the same level.
Yeah.
As you get older, and one knot takes you down, and you don't get as high. I saw that.
And that is that I feel like that graph is the perfect message where, like you said, Renata, it shouldn't be something that we're thinking about when something happens. It should be something that we're doing all the time. And when we look at those master athletes out there who are constantly exercising, you may well have been a master athlete if it wasn't for your CLL diagnosis. They're the ones who recover really well, and we understand that physiology behind them. In fact, we understand quite a lot of their physiology and their biology that we're trying to then implement back into the people who are frail, because we can get them out of there a little bit, but how do we get them above that next level, and how do we get them back to that green zone that we want them to be in, where they're aging normally? That's the tough one.
And could you tell us about the study, because I think we need to hear more how important exercise is. That's certainly exercise, and it's been shown in proper studies that it's better than popping the tablets. Tell us
right,
about
yeah.
New England Journal of Medicine
Well,
study.
yeah, we love that one. So I preach this one all the time when I'm teaching the students, whether they be medical students or nutritionists, whoever they are. I probably put that up all the time. And that was the diabetes prevention program that was, gosh, 30 years ago now. I feel like I'm getting old. Where they tested whether if you gave patients who were pre-diabetic metformin, which was your anti-diabetic drug and still is your anti-diabetic drug, how did it compare to having a clinical lifestyle program that was physically activity orientated with a bit of weight loss in there? And their goal was that you would lose a little bit of weight over a 6-month window, and you would increase your physical activity up to 150 to 200 minutes of moderate intensity exercise. And whether it was surprising or not, the results came out showing that the clinical lifestyle program was better than the metformin. And so the recommendation at the time, right, was that if you're pre-diabetic, your clinician should be telling you that I need you to go away and start doing exercise and diet until it controls your pre-diabetes levels. And then we'll think about metformin to kind of prevent that. And that's kind of run true. Whether that happens in every clinic, I don't know.
Do you think with the current sort of fashion of GLP antagonists,
Oh my goodness, yeah.
would we saw the same changes?
Yeah, that's a question, isn't it? Do you know what I think? So I think that if you do a 6-month exercise program or a 6-month lifestyle program, you initiate a behavior change within people. The majority of people will change their behavior, and they will be more inclined to be healthier in their lifestyle approach.
And I think those injections actually, from what I understand, does force people into a healthier behavior because they feel nauseous.
Exactly, yeah. But the evidence coming out now is that they're regaining the weight. Just like if you have bariatric surgery, a lot of people will regain the weight as well. And it looks like those injections, they're not creating the behavior change because they're relying on the drugs. So
there are no magic bullets, basically.
well, it is, isn't there? It's hard. It's exercise and diet, isn't it?
Hard exercise.
You have to get out there and you have to start moving.
And tell us about effect of exercise on psychology, on cognition, because obviously,
Mental well-being. Yep.
yes, mental sort of
Yeah.
healthy body, a healthy mind.
Exactly. Yeah. No, I mean, Charles, you'll know that there's nothing worse than that cancer diagnosis.
Yeah.
It takes you down and it keeps you down, doesn't it?
Yes.
And being able to refocus or being able to focus on something and make you realize that you've got control over something will bring your mental well-being back. And there's a plethora of information and studies out there showing that exercise not only improves memory, it improves cognitive skills, it improves well-being, quality of life, and it does that through just building your confidence and building your ability to be able to realize that you've got control over your body now. And if you can get control over your body, then you feel stronger. Whether you are stronger or not doesn't matter. You feel like you've got it.
Could you tell us about exercise and onset of certain cancers?
Sure. So yeah, so we so a good 20 odd years ago, we were starting to realize that people who were fitter, people who exercise more, were at a lower risk of developing several different cancers, mainly breast cancer, colorectal, endometrial, and so on. Generally, obesity-driven cancers. And then there was some really great evidence that was coming out of Lee Jones's lab that was showing that if you got a diagnosis of cancer, the fitter you were, the longer you survived afterwards, and the better your quality of life was. And so it's been pretty well known for a long time now that cancer will reduce the risk, so exercise will reduce your risk of cancer development. And there's a lot of preclinical work in animal models that are showing kind of what those mechanisms might be. And some of it is energy, so some of it is fat mediated, and some of it is immunologically mediated as well. Weirdly, the CLL one, there was never, the data that was coming out at the same time, it was never related to the risk of CLL. So physical activity and diet didn't seem to be associated with the risk of CLL, although the latest evidence is kind of suggesting that maybe BMI has a bit to play in the process. And you got to wonder whether, because you've got CLL and it's sucking up those fats, maybe BMI has been masked by the fact you've got the CLL.
Yeah. So tell us what actually, I mean, you already mentioned about the muscles can use up the fat. What else exercise does to our body to make it more resilient? Tell us about the immune story, inflammation, etc.
So that's the interesting part to me. Being an immunologist, I'm always about trying to figure out what the immune system is doing. And exercise is this fascinating concept where every single time you do a bout of exercise, it's like putting your body under a sterile stressor, like you've got an infection. So your body temperature rises, your catecholamines increase, your heart rate increases, your temperature increases, just like you've got an infection. And the response of the immune system is to prepare itself. And so the immune system moves out of the tissues that they're in, out into the circulation. It will then pick up signals if there's something wrong. And of course, if you're just doing a bout of exercise, there's generally nothing wrong with you. But the cells move out into the blood and they start to figure out what's going on. And then when you stop the exercise, they go back to where they were. And they're like, oh yeah, there was nothing wrong there. Let's just keep going. Over time, as you build your fitness and your strength and whatever it is, that constant process of moving your immune system around your body prepares them for when the actual event does occur. And so people who are fitter have a reduced risk of cancer because they've been moving their immune system around the body all the time. And then when the signal comes in to say you've got cancer, the cells that are really good for fighting the cancer are moved out into the blood, traffic to the site of the tumour, and hopefully destroy the cancer before it can take off. Now that's the cellular component of it. There is this inflammatory component as well, where we know that if you're sedentary and you harbour a little bit more weight, you have this heightened inflammation. And the heightened inflammation does a number of different things, but it's really good at suppressing your normal immune system. And so it stops your normal immune system working so well. And at the same time, it suppresses your muscles' ability to be able to metabolize energy correctly. And so as you start to exercise, the immune system realizes that it's been suppressed by the inflammation and it counteracts that and it starts to stop producing as much inflammation as what it normally would do. And at the same time, the muscle needs the energy and it starts to do that as well. And so over time, the inflammatory balance starts to drop to a manageable level, and the body starts to realign itself with the inflammatory balance it should be in.
That's fascinating. I mean, and I also have heard that obviously when that exercise has got the best effect from frail. So when you start frail people, get them exercising, they get far better than fit people. Like Charles, for example. And Charles actually asked one of those questions centered us around, is there a ceiling? So, so tell us about the ceiling and also tell us about that increment. So, so basically fit people, there's no point for them to get much fitter?
There's a ceiling, right? So there is a ceiling. You know, you can be as fit as you possibly can, and you'll probably never get any fitter than that. That's unusual. But there are people out there, and there's age associated fitness as well. And so we know what the normative levels for people of a certain age and a certain sex should be. And then when you hit that, you know, the rule of thumb is that you're probably not going to get that much better, but that's just one marker. And so that's just cardiorespiratory fitness, let's say, for instance. And you might hit 100%, but we see people who are 110%, and we see people who can get a little bit more. And we see people who might be as strong as they think they can, and we can make them a little bit, but the improvements are small, right? Because you're at that ceiling. But that's not to say that they're not as beneficial as the people who are at the lowest. And those people who are at the lowest get the biggest bang for their buck because it happens really quickly. The body adapts very quickly, and they might never reach their ceiling, but because of these huge increments. So then, should we be exercising just the low people and not the high people? No, I don't think we should, because we should still be focusing on the optimal amount that person needs to at least get up a level or at least maintain it. And if you're fit as you can and you stop, you will start going down, and those declines are pretty steep as well. And so there's both sides of the coin. You have to be exercising, everybody. It's just different. I think the expectation out of it should be different. The people who are really frail, you can easily tell them that if you start exercising now, you're going to be able to walk around with your kids, you're going to be able to do this, you're going to be able to get on the beach very quickly. And the people who are really fit, what is your expectation of what is it that you want to get out of this? And we have to be really clear what it is that you want to target, that kind of thing. And so it becomes an individualized component now, isn't it? The good thing for me with the biology is that the immune system changes in both of the populations.
Yeah. So you've got a positive experiment, whichever way.
Yeah, exactly. Yeah, I usually get a positive no matter what.
Good. So people who are actually receiving chemotherapy, and obviously I've heard from patients that they fatigue, they almost bedbound day 1, day 2 post chemo, post treatment. Now tell us about exercise and fighting that sort of fatigue.
Yeah, that's a fascinating concept, isn't it? When you look at something like chronic fatigue syndrome, where the old rule of thumb was that if you exercise with chronic fatigue syndrome, it's going to make you worse. There's still a feeling of that when you're starting to exercise people who are undergoing chemotherapy-induced fatigue, because you don't want them to get worse. Fortunately, the new evidence suggests that actually exercising with chronic fatigue syndrome probably reduces your fatigue. You just have to do it correctly, and it's better than what the current sort of techniques are. And then when you have the chemotherapy-induced fatigue, then again, it's a case of trying to individualize it for what their limitations are at any given time. And it's important that we ask a lot of questions before you start your exercise session. And by doing that, we can still get you at a percentage of effort that will get you the benefits. But at the same time, we don't throw you over that percentage that might then cause you to be tired or excessively tired afterwards. But it's a fascinating concept. And we are currently doing a study in esophageal cancer. And some of these patients are coming in a really fatigued situation where you're like,
and they've got massive cachexia usually, don't they? A group of patients as well.
So the dietitians are getting really good now, and so they're stopping a lot of the cachexia kicking in as much, especially in our clinic. But we see muscle fatigue really rapidly occurring, so they're not as strong, and their increases in strength aren't as big as what they are in CLL. But they come in and they're so fatigued, and you're like, oh, should I really be putting you on the bike for this session? And should I really be doing that? And then you individualize it a little bit, so you might not get them up to the same intensity. And then they walk out with no fatigue, and they're like, yeah, I feel great now. Okay, I'm out of here. And you're like, well, that was just brilliant. Well done. And then they come back in a couple of days later, and their fatigue has not disappeared, but it's not as severe as what it was. And so clearly, we can exercise people with fatigue, even the worst types of fatigue. It just has to be individualized to each person. Although that said, I've got no idea what happens. I've got no idea what would happen if we were to take that patient with esophageal cancer and exercise them too hard. No one does that. It's not. There's no reason to do that.
Yeah.
But I don't know what would actually happen.
There was a Cochrane review, chronic fatigue syndrome, which I've got to say slightly put me off. There was time when they said that exercise for patients with chronic fatigue syndrome is not advisable.
Yep.
Tell us more about that.
Well, that was that, and you can Google search all day long about chronic fatigue syndrome, can't you? And it will come up saying, here's your symptoms, here's what you can do. Do not exercise; it will make you worse. Hundreds and hundreds of sites out there, and the first Cochrane review that came out in 2017, I think it was, that was trying to associate the evidence. There wasn't enough at the time, and their general idea was that exercise didn't seem to be as bad as what they thought it was, but they weren't sure. And then the new one came out last year, and with much more evidence, it is now telling us that if you exercise correctly, so with specialist help to start with for sure, then you will likely reduce the amount of fatigue that you have. And the current clinical guidance for chronic fatigue syndrome is what we call pacing, and so it's kind of just like walking around at certain intensities. But if you have a structured exercise program like cycling and swimming that is not too intense but not too light, then the fatigue reduces better than what the pacing does. So now, I feel more confident that we can exercise people with chronic fatigue syndrome.
Good. And there are obviously a guideline as well. So guideline for exercise in cancer patients. So what guidelines are there?
Well, funnily enough, the guidelines kind of follow what the general guidelines are for the general population. So the physical activity guidelines for people undergoing cancer treatment is 150 to 300 minutes per week of moderate intensity exercise, or 75 to 150 minutes of vigorous intensity exercise. And within that, you should have about 2 sessions per week of some sort of resistance exercises to build muscle or maintain muscle mass. That's
and balance exercises.
And balance exercises, yeah.
And that's been published by ESMO as well.
ESMO, ACSM, the Australia, everybody's published the same.
And we have included in most recent CLL upgraded guideline as well. So we'll be there as well.
Yep.
So moving on, how we can elaborate that exercise in clinical practice. So I know you've got a clinical study underway. So could you just describe basis of this study? And I know Charles is active participant, so it would be good to hear from you, Charles, how different your exercise was.
So the basis of the study is really to try and address this premature frailty. And so what we wanted to do was figure out what the physiology behind this premature frailty might be. And then if we target it with exercise, will we change it? And so to do that, we needed to figure out what the physiology is. So we do a lot of physiological tests, don't we, Charles? We measure a lot of functions, and then we prescribe you an exercise program.
Just give us few examples of physiological tests you do.
Yeah, sure. So we use a cardiopulmonary exercise test, so a cardiorespiratory exercise test. So we can measure heart, muscle, and lungs. We use near infrared on the muscles to determine oxygenation within there, so muscle function, and we measure glycogen levels within the muscle, so we can see what the energetics are.
DEXA scanning as well?
We use BIA, so we use bioelectrical impedance to be able to do body composition, so not DEXA, because it's on a different part of my campus and it would have been a pain. But we would have liked to have done DEXA. But this gives us a really accurate assessment of segmental body composition and see where the changes are. And so we have a number of different physiology, and then we take your blood as well, because we want to link that to the biology. And then we give you this wonderful 12-week exercise program that is specific to your fitness, to try and improve your fitness by anything from 10 to 20%. We use high-intensity interval training, and that might be scary for some people, but for Charles, that was cycling pretty fast. But for someone who is particularly frail, it might just mean walking a little bit faster because it's now specific to that person. And it has some resistance exercises in there. And then after the 12 weeks, we assess you again. And then we ask you to go away for 12 weeks and figure out if you can do it yourself. And this is that behavioral change component where we're trying to drive you to change your own and take responsibility for yourself. And we assess you again.
Yeah, and you've got a control group.
We do have a control group.
So tell me, how do you control for it? Because there will be people disappointed if they don't get into exercise. So how do you control for that?
Well, we learned our lesson. So we did this study first at Duke in North Carolina, and we put a control group in there, and we didn't offer them anything at the end of the control group, and they all went away and started exercising. So if you read that paper, the mean difference for the control group is higher than the mean difference for the exercise group. It's like, thanks, control group.
Well, you managed to publish that one. So.
Well, yeah, we published that one, yeah, but we learned a good lesson from it, and we realised that we actually need to be able to not do that. And I randomized control trials are brilliant. It's exactly what you need to be able to change policy. But when it comes to something that you know is going to benefit you, it seems really strange to me to have to do a control group. So what we did was we said, if you randomize the control group, you're going to do 12 weeks of nothing, just don't do anything, do what you're doing normally, and we'll assess you. And once you've finished the control phase, we'll now give you the exercise program so you get the benefit.
That makes sense, an incentive.
It's an incentive, yeah.
That's fantastic.
Incentive to do nothing.
Yeah.
Actually, to continue as you were anyway.
Yeah, exactly.
Do you actually give to patients like Charles a purpose of that exercise? Is that kind of clarifying a purpose? Is that part of it?
Not as big a part of it as what we would have liked to have been. The purpose was to change fitness as quick as we possibly could. But at the same time, there is a component to it where we're trying to figure out, what do you like doing, and what will you like doing when you're fit and you get out. And so we ask these questions so that we can give them an idea of what it is that they want. And so, forgive me, Charles, it's almost like you've made the decision, but it's really us that's made the decision for you. We just kind of fooled you into it.
And obviously part of your exercise plan is to include progressive overload.
Yes.
Tell me about it.
Yep. So, gosh, I wish I had Ellie in the room. She's like the expert on progressive overload.
She certainly overloaded me.
Well, let's hear from Charles. Why don't we hear example? So, Charles, tell us about your experience and progressive overload. Yeah. What did it look like from you?
Yeah. So I heard those talks. You and Ellie gave a talk one after the other, and that graph on frailty and how you recover, that did shake me. But it was that what you were talking about resonated so much with my experience. Doing some exercise, becoming ill, going back, and it was almost as if when the exercise and an infection coincided, then that's when I went right down. The both were taking away the same reserves, and if you went below a certain level, you were ill. So I heard those talks, and I thought, I want to get on this trial. I want to get that improvement that you were talking about, and went down. I mean, I know you measured a lot of things. It's a sentence for me to say, but there was a lot of work going on by Ellie, your colleagues, you had down there. And it was pretty hard work. You put me on an exercise bike and you made me cycle, and you ramped up the level until I was exhausted, and some weights as well. And you then set an exercise program. And I did think I was going to be on a bit of gentle exercise. You thrashed me pretty hard for those 12 weeks. But there was a certain enjoyment in it, which I hadn't seen in exercise, that the tiredness, the pleasant feeling of tiredness was coming back. The other aspect of it, and I wonder...
Repeat that again?
No.
You don't need to rephrase it. Just repeat it, because I think...
The pleasant level of tiredness was coming back.
That's an important thing.
Which I'd lost with CLL in previous times. And the other thing, and I don't know whether this was by design, Ellie would set a program, and I'd be getting used to doing 6 intervals at 60 seconds, high intervals. So 60-second high intensity on the bike, and then I don't know what it was, 90-second rest, and 6 of those. And I think I've got the measure of this. I can do this. And then I'd turn up, and after I got to the 6, I was thinking I could rest now. But oh no, there was another 4. It was up to 10, and if I'd known in advance that I was going to have 10, I probably would have backed off a little bit on the first one. So I had that was really tough. But whether that was by design that you didn't
design.
Okay.
Yeah.
And likewise, when it went from 60 seconds to 90 seconds, I'd be thinking, oh no. But
that was just progressive overload.
Yeah. Yep. And doing weights as well. And I was doing this remotely. So you had provided for me a Polar Watch. I've since got my own. And your colleagues, Ellie, had access to the account that recorded everything. So she could see how I was performing, and then calibrate the exercise. Well, right at the beginning, you calibrated the exercise to where I was, and you calibrated the increases, I presume, to how I was, the results that you were seeing on the watch.
That's it.
I went back to the gym once, sort of because I was too far away. And then at the end, you gave me another 2 sessions to evaluate where I'd got to. And then the 12-week post session came along. That was quite difficult because it was in the run up to winter. I was at the point where if I had a COVID and a flu vaccine, I'd take them separately, because before they would put me in bed, taking them both together, I was trying taking them separately, but they did knock me back a bit, and that was a week out, and then I had another infection. So trying to maintain that through that 12 weeks, in fact, I'm quite surprised that my results were as good as they were. It was probably a bit longer than 12 weeks with the illness, but it was, yes, there was a lifestyle change, and now the importance of structured exercise and seeing my resilience to illness and seeing my capability, I want to keep it going. So, you have...
Is the 12-week finished now?
The 12 weeks is over. And since then, I'm glad to say I've signed up Ellie as a personal trainer, so she's now keeping the pressure on. I'm not allowed to slack off, and it's that motivation that comes from having a personal trainer who's watching over, but also providing an objective judgment as to when, if I'm saying I'm not feeling so well, that there's someone who's endorsing the fact, okay, back off, take the pressure down a bit, or just relax, go at a slightly lower level, and then we'll build up again. And that's quite important for someone who never learned to listen to his body, I guess.
So obviously you also, because you said that before, I've heard you telling before that we need to treat those patients on exercise program like athletes.
Yep.
So therefore athletes, we hear about refueling, we hear about carb loading. Is the carb loading thing of the past, or we still carb loading, refueling after exercise? So do you have got that as an advice as well?
Yeah, yeah. So that's the goal. And you described the progressive overload perfectly there. And just to put that,
It did hurt.
hurt you, it didn't hurt everybody else. It's just you, Charles.
Okay.
Just to put that into context, the whole idea of this kind of this monitoring, this making sure that you're doing it at the right time and you're doing it at a new amount or a new intensity. One of the big problems with the physical activity guidelines, and for you as a clinician, Renata, is that you can turn around to your patient and you can say, hey, you need to be going away and doing 150 to 300 minutes a week of moderate intensity exercise. And someone might do that, but they'll get stuck at that level. And quite a lot of the time you'll see people never progress. They'll never up the intensity, and then they'll answer your question, are you physically active? Yes, I am. And I'm probably moderately physically active, but actually they're maybe not moderately intensity physically active, they're doing a lot less. And so this progressive overload is important. And we derive that from the athletic world, where we understand that to get adaptation and to get improvement, it's not a case of just doing moderate intensity exercise. It's a case of doing exercises that work the systems that need it to work. And so most older adults, but most adults over the age of 30 don't do very much high intensity work. So that area of energy utilization gets lost.
There's an interesting thing there, if I can come in.
Yeah.
There are two things that cross my mind as you talk. One, I'd hear people say, well, of course exercise is good for you, but I'd struggle to get out of the zone where I'd do exercise and it would make me ill.
Mm-hmm.
The difference is you calibrated the exercises to where I was.
Yep.
And then there was another thought, and it's escaped my mind. It'll come back, and I'll interrupt you again if I may.
Yeah, no, you're right, and that's the key, isn't it? So then it's trying to understand what the metric is of the exercise intensity that you should be doing.
Yes.
And that's not easy to do. We use a lot of technology to be able to say this is literally the specific zone you need to be in. We can estimate it, and you can estimate it in clinic, Renata. You can take what their resting heart rate is, you can take what their estimated peak heart rate is, and then you can work out zones from there, and you can get that over.
I think the other thing for myself, I was frightened also pushing my heart rate too high and bringing along some other illnesses where I didn't know how hard I could push myself.
Let's elaborate on that, because that's the first thing, obviously mean age of diagnosis of CLL patients, 72.
Yep.
Most of them are men. Most of them will have cardiac problems.
Yep.
Now,
So
how much workup do I need to do before I say, this is your maximal heart rate? You need to
background on that.
without angina?
Don't I put a background on that? I mean, yes, I would think I was frightened as to how hard I could push my heart. And I think that's why I gave that anecdote to the thought that I'd be having gentle exercises. And no, you pushed me pretty hard, first of all, on the evaluation, but then on the gym. It was, I was surprised how hard I could take things.
Yeah.
And that's been, and looking back on it, that's been a big encouragement. So that's my lead in to say.
Yeah.
So what's the background medical questionnaire do you do? ECGs?
Mm-hmm. Yep. So
to say you are safe to go and exercise hard.
Exactly. Yeah. So there's a number of things that we do. One of the first ones that we do is this physical activity readiness questionnaire, and that takes you through a whole bunch of questions about your cardiac function and your general health. If it highlights that there's an area of concern, we may need to send you back to your GP to get approval. And then when we bring you in, we do a CPET, which is a cardiopulmonary exercise test. And in that test, we can tell whether there's a cardiac abnormality underlying there. And if there is one, then we would send you off to speak to your GP and your cardiologist, and they would check you out. And they might come back and just say, it's a false positive, don't worry about it, off you go. But that doesn't happen in very many people, to be fair. Even underlying cardiac issues, we can still push you pretty hard. It just has to be within the safety limits. So for you as a clinician, there's definitely safety limits. If you know there's an underlying cardiac issue, for sure we need to do that. And there's guidelines about how much exercise you can do whilst you have cardiac limitations. But our really good clinical exercise physiologists who are out there now, some of them are PTs around the country, are trained in that ability to be able to identify how much you can do safely.
Okay, so we shouldn't be essentially, as a clinician, scared to advocate for high intensity exercise.
But how important is it to make sure that for someone like me going out, that you get the right advice, or personal trainers who know what they're doing, or who have some metric that they can follow? That'd be a question for the general person, as it were.
Yeah, that's
wanting to hit someone who hears this and thinks, right, I've got to do more exercise, but how do I set my levels?
Yeah, no, you're right. That's a really good question, and I suspect that's really individual, isn't it? Some people will be really worried about that kind of thing, and I imagine quite a lot of people would be worried about that kind of thing.
Do you know the training, the qualification, what PT do? Does that cover that aspect?
So our lot, we do the American College of Sports Medicine clinical exercise physiology route, and that allows you then to be able to interpret different components of what the underlying problems are in terms of cardiology, for sure. But a lot of it comes down to we as scientists refer you back over to cardiology, because if the cardiologist says, I've looked at all of this, they're fine, then we are now sure that we're okay with it. And 99% of the time, we say the same thing as each other.
Yeah.
But it's really good to kind of get the clinician. And so if they are worried about it, and you do want to go out and start exercising, and you do want to kind of get up to that level, then go speak to your clinician and say, this is what I want to do. And your clinician should then be able to say, well, we'll send you off for an ECG. If you've got a family history of cardiac events, then maybe we'll look at this, and then I'll send you over to these people who can then assess what your fitness is, and then we can just take it from there. And so speak to your clinical teams, and you can find labs like Minds, and you can pay for tests like what we do, and then you can take that back to your clinician, or they might have a clinician on board, and they would then give you advice.
Yeah.
But it's always a concern. We don't want to cause damage. You don't want to cause damage. And so if you're worried about it, figure it out with your clinical team and get tested somewhere.
Yeah. I mean, you mentioned causing harm. What other harms exercise may lead to, other than obviously what we would discuss with the heart?
What other harms?
Oh yeah. There's sort of I'm kind of thinking what I'm thinking. Joint overuse. Yeah.
Yeah. So exercise is a stress on the body, right? And if there's a part of you that is already stressed, and then you start exercising without knowing about that part, so knee joints, hip joints, then yeah, you might irritate that, and it might cause a bit of damage, and then you have to have that treated. So then a full MOT would be really helpful to kind of get you started, to make sure that you don't have any of these issues. But yeah, there's no doubt.
Building muscles around the joint in question is so important as well.
Yeah.
So it's a bit of a catch-22, and I think
catch-22, yeah.
And I think, as we already repeated here, listening to your body, which you, Charles, mentioned. If there is a pain in a joint, you do exercise, which does not cause pain in the joint, but
and of course you start slow, and then you start to build up, and so this progressive overload becomes very critical at the early stages of doing exercise. And so to avoid the damage, start low intensity, start slow with everything. And then when you realize what you can do with no pain, because you shouldn't have pain with exercise, then you build it up and build up. And for people like that, it may take a little bit longer for them to get to the point where they're now exercising at an adaptation kind of level. They're just preparing the body, and they know what they can do. But yeah, we can get you around that.
Yeah.
And you can get yourself around that by just not going,
exactly.
Not going too fast, Charles, all the time.
So tell us what's the preliminary data from the study Charles participated in?
Well, yeah. So we're nearly at the end of the study. I think we have our last testing next month, which is really exciting. So we recruited 60 people into the study. The preliminary data is that unlike our Duke study, where the percentage change in fitness was about 5%, this one is much higher. We're seeing cardiorespiratory fitness changes, so we're affecting heart and we're affecting lungs, which is great. Muscle strength is improving a tremendous amount, way more than what I thought it would do. So some people are getting 100% stronger on their legs, which is great. Everybody seems to be coming back in feeling much better about themselves.
True for me.
Yep.
Fatigue?
Fatigue is going down through the floor or going up, depending on which way you want to measure it. But it is disappearing pretty much. We are
So you
combating.
managed to shunt that
Yeah.
fatty acid from CLL back to the skeletal muscles
So
and heart.
so next month we head back into the lab to start looking at that metabolic profile of the cells. But we have we do a CBC, so we look at the complete blood counts. And every now and again I'm texting Ellie saying, CBC lymphocyte counts went down 10%, and she's like, oh yeah, cardiorespiratory fitness went up 10%. I'm like, okay, that's really good. And that seems to be happening quite a lot. So anecdotally, it looks like we're changing the biology, and hopefully in the next few months we'll figure out how much we've done that. But yeah.
So I without a doubt, I mean, I sing your praises, and I'm thankful to you and Ellie, because it has changed me dramatically. I mean, I'm my wife would vouch for that. I am far more able to do things, whether it's around the house or exercise.
So you're not flaky. What was the phrase she was using?
Yeah. She called me old flaky, which sounds a bit like the kind of, tobacco you got in bags, which you sort of roll your own cigarettes. And old flaky. She does assure me it's a term of affection. But I'm trying to go beyond that now. But it has changed me. I mean, I also wonder, could I have postponed my treatment if I'd been on this earlier? Because you got better results for the people who are pre-treatment. And is that right?
Yeah. So the treatment naive are improving more than the treated people.
Well, good for them. I mean, I've improved as much as I have. They've got even more improvements. I'm quite jealous.
Generally
We know that patients who are fitter do better on treatment as well. So I think
Okay, yeah.
even
and you're right, Renata, there is that balance thing, isn't there? It looks like the treatment naive people probably started from a little bit of a lower level as well. And so then their increase seems to be much bigger. Yep. But relatively speaking, both groups have improved a significant amount, which is the main thing.
And tell us about dropouts. So who is dropping out and why did they drop out?
Yeah, so
Because obviously, we are obviously proponents of exercise, but we are, let's look at the other side.
Yeah, so that's, dropout is always a big thing, isn't it? And when you do any kind of intervention study, you generally are biased towards the recruitment people. And so you're generally bringing in people who want to exercise. So you don't really need to drive that behavioral change. And then when you look at the dropout of those kind of studies, it's usually about 20% of your recruits will drop out for various reasons, time, whatever it might be, change in therapy, something like that. But in our, we've gotten quite a range, right? We've got a lot of people who are certainly on that frail side of things, and we've got a lot of people who are on that robust side of things. So the fitness range is quite large, and the dropout is actually quite low. We've maybe only had about 4 or 5 people who have dropped out, and a couple of them have been because of treatment changes, and that's kind of out of our control. And so, and then we've had a couple of people who have decided that they don't have the time to do it. But generally speaking, our dropout is actually really good, a lot better than what I thought it would be.
So the time one, I mean, I would have found that quite tough several years ago, especially when I was with this startup company, to have carved out time. And I sort of wonder, if you're motivated, you'll make time for it. But if there's some way that the clinicians could almost prescribe the time, and you could have a doctor's letter to take to your employer or to say, this person needs to make time out. Now, in one sense, you're giving them a free pass to go to the gym, and the other parts of the population go there anyway. So I don't know how you do that. But I just think
it's a culture change, which we do need to change. I know in Japan, that's part, exercise is part of life, part of work.
Yeah.
And I think the me time is so important. But you are absolutely right. I think we just need to...
Yeah. Time is always the biggest limitation. It's always the one that drives a lot of dropouts in most studies. But what I find in the cancer population is if you have a clinician on board who says, you need to do this exercise, it will save your life or it will change your quality of life, then your buy-in is much higher. And so you get a much better adherence and a much lower dropout.
Yeah, and if I could pick up on that, I think this is such an important point, because a prescription of exercise as a hematologist used to be somebody else's problem. I will refer to GP. GP don't have time to do this either. So now, as I mentioned, it is in our guideline, and I think as any clinician, and it's such a fertile time, especially when we give a diagnosis for CLL, and we say, oh, well, I won't do anything for now, for next few years. So the next question usually patient asks, what can I do about it? And this is the time to say, do that prehab, find places nearby which will guide, with the PTs, or if somebody can afford, hire a good PT and do progressive overload type of exercise. So I think, we just need to keep saying, and I think, yes, it's just will become mantra for patients to follow that through.
Yeah. Yes. The ideas that go in my mind, I mean, how do you... I think, how can other people benefit in the way that I have, especially as your trial stops? And is it it's codifying it?
So how would that help you? I mean, now, if you could turn the clock back.
If I was going to get myself when I first had that diagnosis, I mean, I can remember the hematologist saying, the problem with you, Charles, you're an engineer, and you're going to think that you can have an engine change and be cured of this, but I'm afraid it's not like it. You will have to live with it. I do remember that.
Adapt the engine.
Well, yeah, but that one's, I want a quick solution. I'm impatient, I'm afraid. But I remember those words. But I think if my advice to my younger self would be to get on with the exercise somehow, to make the time for it. But also, if there was personal trainers who were especially understanding, especially equipped, especially trained to understand where they're coming from. And it's both emotional and physical training, or psychological, because I'd have to come to terms with the fact that I'm now exercising at a lower level than I was. There is that deterioration. And that's quite a difficult thing to come to terms with. And I have to say, Ellie, her colleagues in the gym, great, so supportive and encouraging and non-judgmental, which is really valuable. But going back, having personal trainers who could mold the exercise program, if there's some metrics that they could see, mold the exercise program, and you would have confidence to know that the guidance they were giving is the right to give you the best improvement, as it were.
And tell me, what motivates you? Because obviously you must have troughs and dips.
I think motivation now is because of the improvement that I've made. The motivation also is Ellie on board's giving me a schedule of exercise and knowing it's good for what I'm doing. And also, as I said earlier, having that second opinion, just back off a bit, ease off. The other thing, I mean, it's what I'm doing. I had this plan back in 2015, 2013 or whatever, cycling the 5 ferries, which is 80 miles around the islands.
But having a purpose.
Yes, so I want to see if I can redo that. Now, if I don't, I think it's almost because there are too many activities coming into my life because I'm more capable of doing it. But I think I should still aim for this 5 ferries ride sometime September, August, to see if I can reproduce what I did 10 odd years ago before the diagnosis.
And what you're really talking about there, Charles, is prehabilitation, right? If we could implement into the clinical pathway, you get diagnosed with CLL,
yes,
or to the point where you go into treatment, you're referred over to prehabilitation. And in a number of different cancers, there is prehabilitation. There is trust, unfortunately, because the NHS haven't quite adopted this as a NHS-wide guidelines. But you can get prehabilitation for surgery, you get prehabilitation for different kinds of treatment, and then you get rehabilitation, especially cardiac and pulmonary. And if we can implement those kind of things in for blood cancers, then you get diagnosed, you get sent over to physiotherapy. Physiotherapy then give you your clinical exercise physiologist who prescribes you an exercise program. And you're maybe only with them for a week or two, but they teach you how to be able to do it.
Yep.
And you come back in on your 3 months, 6 months, 9 months, whatever the appointment is, and you see the hematologist, you see the nurse, you see the dietitian, you get your phlebotomy done, then you go see the PT, and the PT says, "Hey, how are you doing there, Charles? All right, let's do this."
That'd be good.
It's
Does that happen anywhere in the world?
It happens some places.
Okay.
It doesn't happen very much here. It happens in some trusts,
Right.
but not necessarily for blood cancer, mainly for surgical procedures. And it's getting bigger. The movement is getting bigger here.
So I think the message is to find out what's happening in your trust,
That's right. Yeah.
in other specialties, and hopefully
Yep.
use that.
And the cost effectiveness of it.
That's where I was going to come. I mean,
Yeah, there's lots of data saying this is how much it costs to train a person who's in prehabilitation or rehabilitation, and this is how much cost it saves the trust. To me, it's a no-brainer.
I mean,
All the trust should be doing it.
I did get I understood the cost of my drugs, and I'm thinking that's an awful lot of personal trainers and gym time.
Yep. Yeah.
Well, probably we would still treat you, but admittedly, probably later, I would guess.
Yes. I mean, if just postponing it by a year
Yeah.
would have been a dramatic.
And Charles, obviously you are the person who was always active throughout your life. I mean, loads of my CLL patients, they're not, I'm lucky if they tell me that I'm walking. There are many who even don't walk. So what would you advise those patients with CLL who are exercise naive?
I would say, I mean, I want to be careful how they start, what they start, because I kept on trying to exercise and making myself ill. But I'd say even if you start at a low level and build it up, but I think it's this magic ingredient that I say magic ingredient, that makes it sound as if it's sort of unknowable. But effectively, you with Ellie, your team, have worked out a formula, which is this spread of exercises, which you gave me. If that can be codified and so that people could follow it, even if they build it up slowly. I mean, that's what I would have liked. Does that answer your question? I'm sorry.
Yeah, no, I mean, yeah, it does. It does.
But obviously, if we can codify those kind of things, like you say, Charles, we can then give it to anybody, right?
Yes,
Just
and train personal trainers with that. So if you had a list of personal trainers especially equipped to help people with CLL, that'd be gold dust, I think, for the community as a lot. Right. Or let me change around. Then other people would benefit in the same way that I benefited.
Yeah.
And I'm not unique. Hillary, similar response.
Yeah.
And I suspect you got the majority of every one of the people who've gone through your trial are saying roughly the same thing that I'm saying.
Exactly. Yeah. Yeah. So there are community drives, and there are GP referral schemes. So GPs can send you to a gym, and then you can come up and say, "I've got a cancer diagnosis," or "I have cancer," and then you can get access to the gym. Our gym, like the Surrey Sports Park, they just got awarded a national lottery grant to do means testing, so people can come in with whatever condition it is, and then they can get access to the gym for free, or they pay a small amount. So there are these GP referral schemes throughout the country. Some places it's hard to find, particularly up in the north, but down here for sure there is more of that.
I mean, I guess the challenge is when you prescribe something, when you make something free, then is it valued? But there must be ways to try and overcome that. And access to the gym, brilliant.
Well, might I tell you about our new study that's going to start?
Yeah, please.
Yeah. So later in the year we're going to try and do this home-based program, and this home-based program will focus on fatigue, and it will ideally, like you say, codify what it is that person needs to do. Everything will happen in their own home. We'll do physical assessments and physical tests that tell us where the limitations should be. We'll then offer them some sort of program, and then we'll let them do the program. And hopefully that way it will allow us to be able to refine what these these codes look like, and what this way of prescribing the exercise to a general population will look like. So look out for that one later in the year.
Yeah, that sounds exciting. Well, on that, I think we covered all aspects of CLL, fatigue and exercise. And hopefully it's not such a scary, especially high intensity exercise, not such a scary prescription might be. So on that note, thank you to Charles for coming along and David. Thank you all. Thanks for joining us.